Oops. Okay, I think we can start now. Welcome, everyone. I'd like to call to order this meeting of the Health Plan Benefits and Qualification Advisory Committee. I'd like to note again that it's requested that all participants introduce themselves every time they speak. With that, this is Grant Ritter, Chair of the committee. Also, I'd like to point out we are going to have many roll call votes throughout this meeting. So if somebody would move and then second those, it would be very helpful moving along. So to begin that, I'd like to start with attendance, Marcel.
Yes, and in addition, this meeting is being recorded for the minute-taking purposes, as well as for posting of the recording on the of the proceedings on the agency's website. The attendance, roll call for attendance. Grant Ritter.
Yes.
Theodore Doolittle. Mr. Doolittle.
Here.
Okay, you're here. Okay. Mark Schaefer.
Here.
Matthew Brackman.
Here.
Thank you. Commissioner Manisha Tutani from DPH. Jun Goin.
I'm on.
Brandon Riff.
I'm present.
Thank you. Alan Skinner.
Here.
And Paul Lombardo. Thank you.
Okay. Could I have members of the staff and the Access Health Connecticut introduce themselves as well?
Good morning. This is James Michelle, Access Health Connecticut.
Good morning, Susan Rich by Access Health Connecticut.
Good morning.
Rebecca. Okay.
Rebecca McClear, Access Health Connecticut.
Good morning, Daryl Jones, Access Health Connecticut Director.
Good morning, everyone. Glenn Jurgen, Director of Human Resources, Access Health Connecticut.
Good morning, everyone.
Good morning.
Kelly Cody, Plan Management.
Good morning. This is Charmaine Lawson, Plan Management.
Good morning, Jackie Olgin, Plan Management.
Good morning, Marcin Olchowski, Governance Specialist.
Is that everyone? Okay. Well, there was no request for public comment, so we'll move on to the next agenda item. Could I have a motion to accept the minutes of the previous meeting on February 1st?
Moved by Ted Doolittle.
Thank you. Seconded? Could someone second?
Seconded.
Okay, thanks. You better identify.
Brandon, sorry.
Brandon, thank you. Yeah. Okay. Moved and seconded. Could we any comments, edits, changes? Okay. Can we have a vote on that then? Vote to approve?
Grant Ritter.
Yes.
Theodore Doolittle.
Yes.
Mark Schaefer.
Yes.
Matthew Brackman.
Yes.
Jun Goin.
Yes.
Brandon Riff.
Yes.
Alan Skinner.
I abstain. I wasn't at the meeting.
Okay. And Commissioner Manisha Tutani. Not here. Thank you.
Okay, thank you. Motion minutes adopted. Could we hear now from Rebecca McClare regarding updates enrollment?
Sure, thank you. Thank you, Martin. I just want to let folks know Rebecca McClear, the Director of Technical Operations and Analytics here at Access Health. I am getting a bit of background noise, Martin. I don't know if we can make sure folks are on mute that aren't talking so we can all get a good recording. Thank you. Just to let folks know, we're going to be going through some of the highlights today of our open enrollment from this PAT that closed on January 15th. There is a link at the end of the slide deck that's been shared with you that will take you directly to the full report for the 2023 open enrollment season on our website, as well as the prior years if you're interested in reviewing some of those documents. So we're just going to focus on some high points today as we go through. So this first, I want to let folks know At the end of open enrollment, here again, January 15th, we did have 108,000 active enrollees at that time. So those folks were folks who had completed their enrollment into a 2023 QHP medical plan. And that number is slightly below where we were at the end of open enrollment last year. But there are a number of factors that fed into that. So when we were forecasting where we wanted or thought we'd hope to be at the end of this open enrollment, we were right around 108,000. So we were right on our target for our forecast given changes to the system and the overall marketplace. So we're quite pleased to see that. Also, I'm not going to read everything on this slide, but we do have the we're consistent in prior years with about 86% of our population has renewed or retained with us year over year. That's a great sign. Those folks are continuing to leverage and utilize the benefits available to them through our exchange. In addition, we did have nearly 20,000 new enrollees added to our enrollment count this year. A new enrollee or an acquisition from an Access Health standpoint is just someone that did not have coverage, QHP coverage through us in the prior year. So those folks could have been on Medicaid last year. They could have been on the exchange in a prior year, no longer requested coverage due to other circumstances, and have now come back on to the exchange for this year. So that 19,000 is a mix of folks who have been with us before, as well as nearly 7,000 new individuals to the exchange this year. So we continue to attract new consumers to our exchange. Again, that is a goal every year as there's new residents in and out of Connecticut and new people with new circumstances. We do continue to see a pretty steady volume of folks coming on, completing an application and getting determined eligible for Husky benefits for Medicaid. So we did see about 26,000. It's a pretty steady from prior years. So that is just a normal course of business there. Couple things to note, the percentage changes, we did see an increase year over year overall of folks that are eligible for APPC, a slight increase, but 2.9% is an increase nonetheless. And we did see a decrease in folks, this is actually a big one for us, of folks that were determined either did not request financial assistance or were determined to be ineligible. Year over year, that volume dropped by just over 2%. So we're making headway in that group. I know that's a population that there's lots of reasons why folks don't request financial assistance, but we are trying to chip away at that and make sure that everyone who is eligible and wishes to take advantage of the financial help is able to. Any questions on this? Moving down, this kind of carries into, this is our looking at the market share for our medical carriers. So this year, we are going to talk a little bit about both medical and dental, standalone dental. So in prior years, we haven't talked about that as much. So we're going to focus right now on medical. And we're looking at, we see that Connecticut continues to have the largest market share overall. We do see that on this slide, we have it broken out as far as overall market share, but then that portion in blue is the percentage of that carrier's enrollment that is enrolled in a covered CT plan. Given the fact that last year, the covered CT program was fully implemented and expanded on July 1st, we wanted to include the impact of that program as much as possible in our reporting of the open enrollment this period. So one thing we do see, and it's not necessarily visible on this, but when you compare year over year, we do see that overall the Anthem share of the market is increasing. So it did go up slightly, about 8% over last year. And we also see that the Connecticut Insurance Company, Inc., or TICI, is also gaining some market share. Thank you. This next slide is showing from a dental, our standalone dental perspective. Again, as I mentioned just a bit ago, this year we did integrate the dental the standalone dental enrollment process into our existing medical system. Prior to this open enrollment, we were offering standalone dental plans, as you're aware, but folks had to go to a separate system with a separate set of credentials, and it became a bit cumbersome if they had to go to 2 different places. Some folks just didn't understand or take the extra time to do that. So this year we integrated it, we brought it into our system so folks can have one consistent shopping experience for both medical and dental coverage. Given that, we did see an overall increase in our enrollment year over year by 66%, which is huge. Even though the numbers aren't as high as medical, obviously, we're just over 8,000, coming up on 9,000 individuals at the end of open enrollment. It's still a 66% increase over last year's numbers of about 7. So we're very excited to see that. We do believe both the simpler enrollment process as well as the fact that we offered a second carrier this year. Connecticut Insurance Company, Inc. offered some dental plans on the exchange this year. So consumers had a choice between the Anthem plans and the Chi-Chi plans. So those 2 factors we do believe contributed to that increase in enrollment. One other thing to note on this slide, as I call it there, we do have, while the majority of the individuals enrolled in our dental plans also are enrolled in a medical plan through the exchange, there were over 600 individuals that enrolled in a dental plan only. So that is something we offer. You don't have to enroll in a medical plan through the exchange to purchase dental coverage. So we did have quite a few folks take advantage of that option. So I just wanted to mention that as well. Next slide, thank you. All right, this slide is very busy, I will completely admit. But what this slide shows is the number of enrollees that selected each plan on our exchange comparing 2022 to 2023. So they're color coded by carrier. So you can, it's pretty obvious that the Choice Silver Standard from Connecticut Benefits Inc. or CBI has the highest number of individuals enrolled in that, has the longest line, biggest number of individuals. That's pretty simple to see. Things that are not quite as simple to see is the growth that we've seen in some of the plans. So for example, the Anthem Bronze HMO Blue Care Prime with added dental and vision, that saw a 235% increase in enrollment year over year. Now, obviously, I'm not in the heads of those individuals, so I can't necessarily say why everyone chose that. We can certainly do some fact finding and find out, but just the fact that that was a significant growth from just about 2,200 to over 4,000 individuals. That's great to see. And for sure, I feel that probably contributed a bit to Anthem's increase in market share. The other thing to note is around our silver plans. Again, even though the raw numbers can be a bit misleading, or not really misleading, but you can't, percentage-wise, you want to look at things compared a little bit easier. Our Connecticut, again, Connecticut Silver Plan is the largest number. The Chi-Chi Silver Plan on the other did see it grew by 53%. So that's, again, a significant number of folks chose to enroll in that Chi-Chi Silver Plan this year. So actually, all 3 of our silver plans did see an increase in enrollment.
So for that numbers, it's just the same snapshot in time because.
Yes, both of these numbers are taken as of the last day of open enrollment each year.
Thank you.
Yep. Thank you. And this slide just kind of breaks down looking at percentages of our population enrolled by metal tier. We do continue to see the majority of our population is choosing to enroll in a silver plan. That's pretty consistent. Is hovering now around the 50%. We do see, however, in the last couple of years, an increase in enrollment in our gold plans. And compared to 2020 and 2021, we do see that increase. More than likely, the increased financial assistance is probably a factor there. It's allowing folks to buy richer plans for the same amount of dollars. But again, bronze and silver do continue to be the lion's share of what we're seeing year over year. Thank you. The next slide, just coming out, we talked a little bit earlier on about the financial assistance, the proportion of our population that's eligible for financial assistance. And we see here that the majority of our enrollees do receive some amount of financial assistance, whether that's APTCs only or also the CSR benefits. I do want to mention that, and I mentioned a little bit earlier, that last year we had 16.2% of our enrollees either did not request or were not eligible for financial assistance, and that number went down to 14.1 this year. So again, we continue to try and get the word out to folks who choose not to request financial assistance, let them know benefits are available if they choose to use them. So we continue to reach out to those folks and try and make headway there. But we can't obviously force folks to provide us their income information. It's also leading into this one, I just mentioned that of a large portion, right, there's that overlap of APTC and CSR eligible folks in our covered CT enrollment. Right, so about I think 40% of folks that are eligible for covered for the APTC and CSR benefits are also eligible for the covered CT program. So it's not everyone that's eligible for the CSR benefit, but it is a nearly half. So that's a great benefit available to those folks as well. This slide is showing, kind of visually showing that we, by that financial assistance level, and it breaks down enrollment into the various metal tiers. So we do see it as expected, the majority of folks that are eligible for APTC and CSR do enroll in a silver plan. There are those outliers, and we break that down a little bit in the next slide, so we'll talk that in a minute, but the majority of them are enrolling in that and taking advantage of their CSR benefits. There was one more thing. Sorry. Looking year over year, that, again, our benefits, the enrollment is fairly similar there. Coming to the breakdown of those folks that are enrolled, are eligible for CSR benefits, but are enrolled in gold or bronze plans. And some of you may have seen this slide before because we have talked about it here and there. We do see a large volume of those folks are eligible for that 73% CSR tier. And as our plan management team will talk to you about that, those folks, for whatever reason, are choosing to enroll in either a bronze or a gold plan. That could be based on their health situation. They may not feel they are going to utilize the plan as much, so they choose a bronze plan with a lower premium and kind of cross their fingers they aren't going to need to use the plan as often. Or it could be the gold plan has some richer benefits that they want to take advantage of, and they therefore choose not to enroll in the CSR. I can't, I don't have insight into all the reasons. We can certainly, we're discussing how to get some more information from these folks to understand their rationale, but we do see this breakdown overall. As mentioned on that last stat, we are seeing that volume of folks that are eligible for CSR and not enrolling in a silver plan decreasing year over year, slightly, but decreasing. Thank you. This slide, I think some of you may have seen in years past. It's really comparing our top 5 plans broken down by subsidized and unsubsidized based on enrollment numbers. So not too many surprises year over year. If we look, there's pretty much the same 3 or 4 kind of shifting each other around each year. The big difference this year for 2023, obviously, is with the Passage plans being discontinued, they fell off that top 5, and it made room for a couple other new plans to pop up into the top 5 from the enrollment numbers perspective. But overall, we continue to see the Silver plans being the top 2 for the subsidized enrollees. We see Bronze being the top 2 for the unsubsidized, with the Silver plan coming in 3 and 4. So certainly, a consistency across the board. But again, with the discontinuance of those plans this year, the Passage plans this year, it did make room for some new plans to break into the top 5.
Hi, this is two. This slide doesn't show consistent with the previous slide, where 2022, the Choice Silver Standard Plan has 37 and then a drop down to 35. But the other slides show it an increase.
So again, these are this is broken down further into subsidized and unsubsidized.
Okay, right.
So the prior slide is total, doesn't take the breakdown of subsidized versus unsubsidized, but they should total up to the same. The next couple of slides are just breaking I'm going to talk through our overall enrollment, breaking down by age and gender. I want to focus a little bit on the age side of things. This first one is our medical population, and you'll see that overall, our medical consumer on average is 44.3 years old, but we also can see that nearly 40%, if we add up the bottom 2 buckets here, nearly 40%, actually 37.9, so nearly 38% are over 55. So we do see, and by the darkness, right, it's kind of a heat map, by the darkness of that grand total of the 55 to 64 band, that's the largest percentage of our enrollment for medical falls into that age band. So just something to keep in mind as we're looking at the plans and the enrollment. Our audience, our membership has been gradually increasing in average age over the past 5 or 6 years. When I look back over the past 5 or 6, it's the average age has increased by just over 1 year, which doesn't seem like a lot, but when you're looking at an overall population of over 100,000 individuals, that to move the needle by a year is actually pretty significant.
It might, not for now or today's discussion, but it might be interesting in the future to look at how that compares with the overall Connecticut population's age breakdown too, just so our potential audience pool, our customer pool, and how we compare, right?
Okay, yeah, fair enough. Thanks, Matt. Right, take that note down. If we go to the next slide, kind of a similar breakdown. This is looking at our dental enrollment. So as I mentioned earlier, nearly all of our dental enrollees are also enrolled in a medical plan. So we would expect the breakdown to be somewhat similar. But what you might notice is the heat map changes a little bit, right? It's no longer focused on that 55 to 64. It's spread a little bit more evenly across between 26 and up. So the reason for that is the average age gets pulled down a bit, right? Down to now 42. So it's a little bit younger. Also, we talked about those 614, again, folks, numbers are fun, right? The 600 folks that enrolled in only dental, the average age of that group is 39. So that volume of folks that chose to enroll only in a dental plan bring our average age down quite a bit, right? So they fall into that middle tier there. So just to keep, one thing we're looking at as we're looking at those dental plans, that 26 to 44 are working age folks. If you've been out there for insurance, a lot of times employers only offer medical. They need somewhere to get their dental coverage. They can come to us and get that dental coverage. So that's a great sign that folks are aware of the benefits that we offer to them and a place to go to get their dental coverage. Thank you. All right, next couple of slides are fairly self-explanatory. I'm not going to go into them too much. I think folks may have seen them, but we are looking at this breakdown of our medical coverage by FPL level, right? So we do see an increase due to the increased benefits and the Covered Connecticut program of enrollees under the 250% threshold, but we continue to see our largest percentage of 17% fall within that 300 to 400% FPL. So, again, that's been pretty consistent in that bucket year over year. We do see a little bit more volume in the folks over the 400% compared to last year, but again, we continue to see that those middle 200 to 400% being our largest volumes of enrollment. Coming down to the next, we're going to take those same buckets and look at it a little bit differently. This is now looking at the average monthly premium after the subsidy's been applied, right? So you can definitely see the sliding scale. We know that the folks at the lower end of the FPL would get more subsidies, so their premium amount would be less. So you see on average, folks in that 150 to 200 range, which is right around the top of the covered CT folks, on average, they're paying $18.72 in premium for a month. Keep in mind the covered CT folks would have zero, right? So they're going to pull that way down due to those covered CT benefits. And then obviously as you get higher and the APTCs go away, their premium increases significantly. Next slide. Again, this is kind of just looking at that monthly premium after APTC by if they have assistance as well as by age band, just to give an indication of where folks are and how much they're paying on average, again, after their APTC has been applied. That's all I have to go for my slides at this time. Are there any questions before I turn it back over to Martin? And again, that full slide, the full presentation or the full open enrollment summary report is available on the Access Health website. The link will be at the end. And again, if there are any questions, please feel free to reach out. Thank you.
Great, I'll jump in here. I am Brad Haywood from Wakely Consulting. I am stepping in for Julie Andrews, who is currently out right now. Quick bio, I am a consulting actuary, been with Access Health for the past 4 to 5 years. Quickly here, a few updates from the prior meetings that we want to cover. But really our agenda is fairly similar, following up on some of the AVC updates, such as the changes to deductible MOOP, some of the proposed regulatory changes, the proposed changes to the AVC, and then again, the preliminary 2024 calculator results. So if we could jump forward. So yeah, the first item we want to talk through are really the follow-ups from the prior meeting. And so if we can jump forward one, so there were some updates to the plans that we wanted to make. This is a really high-level, quick overview of what the changes were to the actuarial value. So whenever we make a change to one of the benefits, obviously the actual amount the insurer is responsible for will change as well. So if the benefit increases or decreases, the insurer or the carrier also will have an offset based upon that benefit change. So the two that we were really looking at are changes for deductibles and MOOPs. And right here, what we're showing is essentially what the value would be for a change in deductible in the MOOP of about $100. In short, what we're seeing is that $100 change to deductible and MOOP is higher from the deductible perspective for those more richer plans. So the gold or the 87% CSR, the 94% CSR really had the biggest impacts. The MOOP will have a similar impact for gold, but is actually more when it comes to silver, bronze, or more of those less rich plans. Now, I did want to caveat or comment on one item here. The gold plan, the reason we're looking at it here and looking at these benefit changes is really due to changes from outside of the calculator. Since the calculator only holds certain benefit structures, given differences with how the plans adjudicate claims and how they handle changes outside of the calculator is why we're also looking at the gold plan. Any quick questions here before I move on? Okay, perfect. Now, another follow-up was to look at actual 2019 through 2021 data. If we look at actual Connecticut data, how many or what percentage of the population was meeting their deductible and what percentage was meeting their MOOP? We focused this study on the standard gold plans, and what we saw is a lower percentage of the overall population that was meeting both of these items. Now, from 2019-21, on the deductible side, we saw anywhere from 15 to 30%. So maximum of 30% of members are actually meeting that deductible or that $1,300 deductible range. This gets further decreased when we're talking about MOOP, where it's only about 2 to 10%. So again, from the same 15 to 30% hit to deductible, we then expect a lower percentage to hit the overall MOOP, which has been about 5,000 to 5,250. And that's what we're seeing is only about 2 to 10% within this 3-year time period that have hit that MOOP. Any quick questions here? Okay. We can move on.
Brad, could you
yes
do that for the silver plans or the bronze plans?
Well, we can look at it. I don't have the numbers off the top of my head, but I can follow up with Julie if we have those numbers and can follow up.
And I believe, Grant, the request from the committee at the last meeting was only to do with the gold plans.
Okay, but that's kind of foolish of us since the gold would be by far the most highest.
Right, I think it was about the proposed change Wakely had proposed to the carriers for the MOOP.
Yeah, no, I
gold plans.
understand. Yeah. Changing the gold. Right.
I think the intent of the data is we throw on the table several options that we consider. So the data would help us to nail down which option should be.
I think it's been a much longer sort of interest of us, just what percentage of people in bronze plans actually meet their $9,000 deductible. And it probably is pretty small. Okay.
I have a question, Grant. This is Ellen Skinner. I've been chewing on this. What percentage of the people over 65 have Medicare, and this is full replacement for Medicare, or is this a WRAP program?
So people, Ellen, this is Susan Richby. People who have Medicare are not eligible to buy in the exchange, the anti-duplication clause. We do have some enrollees over 65 in QHPs, and those are people who usually come to this country in retirement and aren't eligible for free Part A for Medicare.
I got
you. So, they do have the option to, instead of having to pay for the Part A premium, they can, come through the exchange, and depending on income, could be eligible, for subsidy as well.
Okay, great. Thanks for the clarification.
Perfect. Now, I'll start off by saying there are no new updates, really, since the last time that we were talking through this. So rather than rehashing all the different components, We have, again, just supplied the regulatory changes, some of the proposed MOOP and deductible ranges, but we can keep moving through this as there are no updates from the proposed rule beyond what we have discussed. So again, talks about the UVC and the trend, demographic weights, the copay change, but this is all stuff that we have talked about in prior discussions. So we can move forward one. Now, I will mention here, this again is something that we have shown in prior presentations, but just to reiterate, the red numbers on the bottom of each of these tables, this is indicating that the AV, or that actuarial value, is falling outside of the compliant range, which is why we are going through and modifying the plans. So every plan that is outside of that range, per the issuers testing those plans, has to have some sort of benefit structure change. We can move forward one slide. Perfect. Quick note here, the plans have reviewed these options that we'll be coming up with. So they've reviewed them for mental health parity and for compliance. So just wanted to quickly note that. For the gold plan options, what we have on the left is what the current plan is. The three options we have to the right are different components and different adjustments that when we think about that prior analysis of what percentage are hitting deductible and MOOP, or to help kind of influence this decision here. So the first option is more of an impact to the MOOP. This is a bigger jump from the 6,000 to 7,375. The option 2 incorporates a small adjustment to the deductible, a $100 increase to deductible, which has about 175 decrease to the MOOP, still decent adjustment upwards from the 2023 MOOP. And then with option 3, with a $300 adjustment from the original deductible, but with only a $1,000 increase to the MOOP. So all three of these plans, we have had the carriers test, and they did pass both mental health parity and the compliance AV testing. So I will open it. I believe we're deferring to a vote on these different options, or if anyone has any questions, but I would defer to the Access Health team on that one.
Before we move to that, just a comment on option 2 and option 3. We also did further tests on option 3, 2, and 3, where the maximum out-of-pocket can go down as low as $6,150 on the maximum out-of-pocket and still pass the test. And on option 3, the maximum out-of-pocket can go as low as $6,500 and still pass the test. So just a comment from Anton.
Just to put this in perspective, 30% of the people would probably experience reaching the deductible, but only 2 to 10% would actually reach the out-of-pocket maximum. So I mean, that's basically the trade-off between option 1 on the one hand versus 2 or 3 on the other hand.
I agree with that. Yes.
Yeah. Does anybody want to make a comment about which of these 3 plans and 3 options they like the best?
Yeah, it's just a comment. It's a for someone who hit the maximum out-of-pocket, by changing the maximum out-of-pocket by over $1,000, those members will hit the most. And then you are right, on the other side, on the flip side, you have more people hitting with the deductible. So it's just a matter of the magnitude versus like the probability of hitting the deductible, I think.
Yeah. I for that reason, I didn't realize it was a 30% versus 2 to 10%. I sort of like option 1 the best, because I think it's sort of like keeps the most people, benefits the most people, basically, because they'll start getting benefit from $1,300 instead of waiting until it's $1,600.
I guess I prefer option 2, which kind of splits the difference. Because I think the ability to protect folks at the top end matters, even though it affects fewer people.
With one observation here that sort of surprises me, that you're upping the deductible by $100 and you only can lower the maximum out of pocket, which affects far fewer people, you know, at most a third the number of people. And you drop it by $175, you know, in other words, there's something weird going on there.
Yeah,
because
well, and my comments earlier is to that point, is you can lower the maximum out of pocket even further than what it has shown here. Like option 2, you can push it down to $6,150, which is only increasing from $6,000 to $6,150. So if we go with option 2, option 3, we need to lower the maximum out of pocket a lot more than what is shown in this table.
Why wasn't that proposed?
So one of the, if I can speak up quickly here, if you look at that bottom row, those are the AV calculator results when testing with the issuers. So we see a wide range with option 2 and option 3. Option 2 with an 81.2 to 81.78, option 3 up to 81.94. You can't go above the 82. So if we drop it much lower, there is a good chance one of the issuers or something would come out of that EV compliance. So that's really what we're looking at here, is more of a market wide result. To answer the other question on MOOP versus deductible, Grant, that's what really that first slide looking at the change in deductible and MOOP was going over. The gold is almost symmetrical when we look at changing it by $100, but the variance between deductible and MOOP and the impact it has to the AV gets wider when we move to silver and bronze. So it's really this gold where you're seeing that symmetry within the change to deductible and the MOOP, but it does get more drastic material when moving to the other plan types.
Yeah, no, I would have thought it would have been asymmetric even for the gold, but it's much closer to being $1 here or $1 there.
So this is Ellen. If we kept the $1,300 deductible, do we know how many people were within striking range of that 1,300? Like, what, you know, did they buy dollars or did they miss it by hundreds of dollars? Is there any way of knowing that? Because if we could see more people hitting the deductible and getting the benefit, the higher benefit, that would influence the decision.
Yeah, we don't know that. Yeah, I understand. I mean, 30%, I guess 30% hit the medical deductible in the past 3 years. I mean, it was all much lower back then anyways, but because it was only 19 through 21 and we're already up to 22 now. But obviously fewer people would reach the deductible if you raise it $100. And they'd be out $100 anyways.
About that, cost of drugs going up, all the cost of services going up, and the volume of services. If we believe that, I think there'd be more people that would reach it. It's just.
Oh yeah, no, I mean, percentage-wise, maybe. I mean, that's what I'm saying. Every year it's going to change because it just cost goes up, and therefore they're more likely to meet it. But I assume you would be around 30%, even at $1,400. It's just they'd be paying $100 more.
Brad, can you go back and validate your option 2 and option 3? It's inconsistent with what we share with your team.
Review the analysis and what the results were.
No, reviews what we sent to you versus what you present in this exhibit.
Yeah, we'll take it back. It should be falling within that range down there at the bottom, but we'll definitely take it back and confirm that that is accurate.
This is Mark. This is a rudimentary question, but which I should probably know. So the range within which we need, I'm having trouble understanding what the updated federal AVC requirements are and how the newly calculated options fall within those that new range.
Well, the new requirement's 80%, but you're allowed a 2% variance. So you could go up as high as 81.99.
Understood.
Yeah, the biggest change year over year is essentially the trend or the underlying data applied. So when Socio comes in and updates the data, the trending, it changes all the different levers and the impacts based on plan type, metal type, benefit tiers. So that's really where we see that the AV increases every year. Since less and less, it just changes the underlying data, which causes different benefit changes to be needed. But to Grant's point, that 2% upward adjustment is fairly constant.
We've
Thank
always
you.
offered plans that are on the rich side with higher premiums, obviously, but we've always tried to get close to the top end of the variance. I mean, we don't aim for 80%. We aim a little higher than 80%, even though that's
So this is Ted. I just want to make sure I understand the dialogue here between Brad and two. So two, what you were saying is that for plans option 2 and 3, for Anthem, you could go lower on the MOOP. And then I heard Brad say, yes, that might be true for Anthem, but it's not true for everybody in the marketplace. Am I capturing what each of you said?
That's right. Each carriers have to use their own calculator or their own data to do the test. So it seems like on our end that when we do the test, we can lower the maximum out of pocket a lot more than what is shown here. But I can't speak for Connecticut.
Yeah, this is Brandon. I'm just looking back at some of the numbers. I don't think from our testing we could say the same.
Okay.
And just a reminder, there's always that challenge with meeting the AV as well as parity. And to the point you made, the carriers have to use their own claims data, especially for parity. So, you know, they can really come up with different results on this.
So let me ask you this, and this might be a question for Susan. So once this plan is set, and say we went with just for instance, let's say we went with option 2, and it was a 7,200 MOOP. A plan has to offer a 7,200 MOOP, or can they do better if they're able to?
No, for these are the standard plans, Ted. So for these plans, this is, you know, the board committee and the board are setting the cost sharing amounts for the benefits for the standard plans. They can have a non-standard plan and, you know, go in a different direction, but these are for the standard plan options.
Okay, I thought that was the case. Just wanted to validate. Thank you, Susan.
Okay. I'm supposed to have a vote here, but we need to have a single option to vote on it. We're supposed to make a recommendation to the board of directors who meet, mid-March. I don't know. I'm willing to take Mark's sort of compromise idea. If that's okay with everybody else. I mean, it is true that the carriers can offer an alternative, a non-standard plan as a gold plan, and maybe take advantage of one of these other options as well.
Well, for what it's worth, I was persuaded that option 1 was a reasonable way to go. So
okay, well that's good. Maybe option 1. How do other people feel? I'm sort of in favor of option 1 too, but I did want to sort of get the sense of the committee.
And I agree with that. I mean, if we cannot lower the maximum out of pocket for option 2 and 3, it makes sense to go with option 1. Yes.
So I'd be happy to make a motion for option 1 unless you want, because after the motions, we could have more discussion. So I'll make a motion for option 1.
Okay, thank you. Seconded?
I'll second it, Matt Brockman.
Okay, all right. Any other comments? Discussion?
I'm sorry, who made the motion?
Mark Schaefer made the first motion.
Thank you.
And
Is there any discussion on the motion?
Matthew made the second.
Okay, thank you.
Well,
Okay, Mr. Chair, you want to read the? Would you like to read the?
I guess we'll have a vote. The motion is to accept option or make a recommendation to the board of directors for option 1. And we can now have a vote on it.
Okay, Grant Ritter,
Yes.
Theodore Doolittle,
Yes.
Mark Schaefer,
Yes.
Matthew Brackman,
Yes.
Jun Goen,
Yes.
Brandon Riff,
Yes.
Ellen Skinner,
Yes.
Manisha Sutani. Not present. Thank you.
Okay, I guess we move to the silver plan.
Perfect. Yeah, this first slide is just giving an overview of what is currently offered for 2023. So as an idea, the silver plan itself is not outside of the appropriate range, but the CSR plans are. So again, in the bottom row, we do see that they fall outside and need some sort of adjustment. So if we move to the next slide, given adjustments are small and we have to maintain other regulations that are in revolve how they correlate with the overall standard silver plan, what we only have is one option for each, which are small adjustments to the MOOP. So I believe option 1 for the 73%, 94%, they are slight increases. The 87% is actually a minimum decrease. So again, if we jump back to the prior slide to look at what those MOOPs are, we have 7250, 3000, 950. Then if we jump forward again to the next slide, we see a moderate increase to 73, 94, slight decrease to 87%. But given the complexity of CSRs, what we have are these options for the CSR plans. So again, I'll defer it to Grant and Access Health team for any voting.
Well, I want to thank you for for looking into this and for coming up with very, very minor adjustments that meet the bill. So I would entertain a motion to accept this, and then, of course, we can have a discussion on it afterwards.
So moved, Matt Brockman.
Thank you. Second?
Second by Ted.
Okay. Second by Ted. Good. Just a question. How big a change are we talking about here? Are these $25 changes, $50 changes? What are they?
To the MOOP, I think 73, if we jump back to the prior slide, it's a bit more.
72.50, so it's
yeah,
okay,
225 to 73. It's $75 decrease.
$225 there. It actually went down.
Went down on 87 by $75, and I believe 94% was 150 up.
Okay. Okay.
Oh, less.
50, 100 up.
Yes.
Okay. All right.
100 up.
Yeah, I think this is totally acceptable. What do other people think?
Yeah.
Any decision? Okay. Then could we have a vote on recommending this to the board of directors then? Marson.
Okay, Grant Ritter, Matthew Brackman,
Yes.
John Goen,
Yes.
Brandon Riff,
Yes.
Alan Skinner,
Yes.
and Manish Sujani. Thank you.
Okay, moving to the bronze.
Perfect. In a similar vein, we had a very minimal update to the maximum out of pocket. If you note down at the bottom, it does put us right on that precipice of 64.97%, which indicates this is about the best option outside of further refinement into the different copays or anything, but it's about a $300 increase to that maximum out of pocket. So again, I defer to you, Grant.
Yeah, no, again, seems like the reasonable, logical thing to do. I mean, we've learned a long time ago that the only thing that really moves the dials are either the deductibles or the out of the move. And this is this is right there on the edge. So this seems to be the minimum change that will do the job.
Yep.
Okay. Could I have a motion to adopt this then?
Motion to adopt.
Thank you. Seconded.
Seconded.
Okay. Any other discussion, comments? Oh, thank you. Marcin, can we have a vote?
Grant Rader,
Yes.
Theodore Doolittle,
Yes.
Mark Schaefer,
Yes.
Matthew Brackman,
Yes.
John Goen,
Yes.
Brandon Riff,
Yes.
Alan Skinner,
Yes.
and Manish Tutani. Thank you.
Okay, moving to the HSA bronze.
Perfect. This is going to be a very similar story. So here we just summarize the benefits, what's not subject to deductible, what is after deductible, for some regulation, but really overall story is similar of a $225 increase to the MOOP, which again puts us at 64.94%, which is right on that cusp of kind of the highest of it that we can go there, or the most favorable impact. So.
Thank you. Let's have a motion for this, and then we can discuss it if there's any discussion. Can I have a motion to accept?
This is Ellen Skinner. I accept.
Thank you. Motion. Yeah. Seconded.
Seconded. Mark Schaefer.
Thank you.
Discussion. My only comment is I'm happy that it's as small a change as it is, you know, given inflation and everything. So, and this seems to be again the way to go. Any other comments? Okay, and then Marcin, could we have a vote on this?
Yes, Mr. Chair. Grant Rader,
Yes.
Theodore Doolittle,
Yes.
Mark Schaefer,
Yes.
Matthew Brackman,
Yes.
John Goen,
Yes.
Brandon Riff,
Yes.
Alan Skinner,
Yes.
and Manish Tutani. Thank you.
Thank you. The dental plans, I guess, are next. Oh.
So, yep. So this is Kelly, Kelly Cody from Plan Management. So there is a follow-up actually on this this presentation. This was requested at the last meeting in February. There was some question about what would be the impact to the overall rates should the maximum out of pocket change by $25. And so Wakely was able to go back and review that information. On the screen, it's showing it's offsetting pricing adjustment of -1% to -2%. But I'm not sure if Brad wants to add any additional talking points to that.
Yeah, only comment I would make around the -1% to -2%, since premiums are largely based upon the actual experience of the carrier. What we're looking at is not, their individual experience, more of an aggregate study. So that's the result of the range. When adding the $25 change to the MOOP, obviously, The various carriers will have different adjustments there or different pricing. So what we have is essentially a range of an estimated pricing adjustment.
Thank you, Brad. One other follow-up as well. I think it may have been Ted. If not, I apologize. Somebody had asked for the rates by plan. So on the screen, that's what we've presented here. It's under 8, it's 25 and under, and then 26 and over. And so the plans obviously highlighted in blue are the standardized dental plans offered through the exchange. These are all on exchange plans as well. So if there are no further questions, we can go on to this. So using the information that Brad had presented, I believe the group wanted to understand what the impact would be if they did consider changing the out-of-pocket maximum. Again, just as a reminder, the Feds had calculated new amounts for 2024. We could go up to $400 for one child and $800 for 2 children. So at this point in time, I think it's the conversation of, do we want to make changes to the plan? So I'll pause there.
Okay, I guess if we made changes, it would either be $25 or $50 for one child and $50 or $100 for 2.
Correct.
Does anybody want to make a motion to change, or maybe we just keep what we have? I mean, we're seeing a motion to change would lower the premiums by 1% to 2%. Which would be between $2 and $4 or something to the basics.
I don't see a reason to change unless.
Thank you. Yeah, I mean, me neither. Do we need a vote if we don't make any changes?
No, there's no vote needed if you don't. We were just, as we've done over the last few years, we just, always wanted to make sure that the committee was aware of these possibilities and consider it. And I think this was good, that Wakely gave us that additional information the committee wanted about the potential impact on premium. And if you don't want to make a change, then we're good to just stick with the standard plan that we've been using.
Great, thank you. So I'll ask once again, is anybody interested in making a motion? If not, I think we can move on. So the next thing we do is look at the plan year timeline. Kelly?
Yep. So as Brad mentioned, nothing has changed at this point. So the timeline stands as is. And thank you very much for everybody's hard work on this. The one thing that hasn't changed on this slide is that the carrier rate form filing is for June 1st. So getting through this was a great effort with everybody. So again, thank you very much. Next slide, please. And I will leave it to Susan to confirm if I'm correct or incorrect, but based on what we have just gone through and have all the approvals for the plans from you to recommend to the board of directors, I don't believe that we need to have the March 13th meeting.
Great.
So yeah, that is correct. So we've got all the recommendations that are needed to present to the board.
Great. So I think there's one thing that I do need to note though, because the notice of benefit and payment parameters and the actuarial value calculator for plan year 2024 continue to be in draft status, and also that the IRS information for the high deductible health plans information as well doesn't come out until the spring. There, just as a reminder that there may be a potential for possible tweaks to the plans if the maximum cost sharing limits are changed. So, you know, we are doing this in, you know, before everything is in final status. So, we just wanted to make sure that everybody was aware that there is a potential that something could change. Unlikely, but could.
We have unfortunately encountered that a few times in the past, and it calls for a special meeting of some sort. But barring that, we will present these to the board of directors at their meeting. Great. Any other comments, Kelly, next steps or anything along that line?
Yeah, I think for next steps, we're going to put this information together, and I believe there will be a special meeting called for the board of directors to vote on these plans. So, and then one last thing that I wanted to mention, Rebecca did note that within the appendix of this presentation, there are links to the 2023 open enrollment, which is the full presentation, if anybody's interested in taking a look at that. Other than that, I don't believe I have anything else to comment.
Okay, thank you. I will call for a motion to adjourn in that case.
Moved by Ted.
Thanks, Ted. Second?
Second.
Oh, okay. Martian, could we have a vote to adjourn?
Grant Ritter,
Yes.
Tito Doolittle,
Yes, thank you.
Mark Schaefer, Matthew Brackman,
Yeah.
John Goen,
Yes.
Brandon Riff,
Yes.
Ellen Skinner,
Yes.
and Manisha Sutani. Thank you.
Okay, thank you, everybody. We are adjourned.
And I just echo the thanks to the committee members and Wakely. We really appreciate your work on this.
Yeah. Okay, then. See you at the